Welcome back. Today I would like to celebrate the 100 years of insulin therapy. I know most of my patients, when I say insulin, they hear death threats because that is kind of how I scare them straight. Like, you don't behave, we're going to put you on insulin. Right? Especially with diabetes, right? Because nobody wants to inject himself multiple times a day, right? So insulin therapy kind of got bad rep for, the therapy where you have to like hurt yourself multiple times a day. But the truth is, insulin is actually a life-saving therapy. Let's go back to 1922 when the first patient, type 1 diabetes patient, a 14-year-old in Toronto, Canada, received treatment with life-saving insulin therapy for his diabetes. And this was a major breakthrough in medicine, because prior to that, patients diagnosed with type 1 diabetes only had weeks to live. And the most life-saving therapy that we had at the time was using something like ketogenic diet to try to preserve their lives maybe a few months longer, where they wouldn't eat anything that had any carbohydrate or glucose or sugar in it, and mostly high fat, to try to make sure their body didn't need insulin to process their caloric needs. And that was the only therapy that at least allowed these patients to live a little bit longer, but it was not an enjoyable life. Like, they were very restricted. And of course, a lot of them were in hospitals and being monitored and prodded. And when insulin came along in the early part of 1922, it became a therapy that we could give to patients via injection to then mimic what insulin is supposed to do in the body. So for those that don't know, insulin is the hormone that our pancreas, right, releases into the bloodstream the minute the brain senses that you've put anything with glucose or sugar or carbs in your mouth. And as soon as that signal is realized, the pancreas immediately starts to make insulin to prepare for the feast that's coming into the stomach and then into the small bowels, to be able to break it down, absorb it, and turn it into energy. So when patients are born without good functioning pancreas, they're not able to make the insulin in their beta cells that live inside the pancreas. And without insulin, the sugar or the breakdown of carbohydrate in your body just becomes a very toxic sugar that's running around in your bloodstream, causing problems. So your body needs the insulin to drive that sugar into your cells, so that your cells can start to make units of energy from that sugar. And that energy is what we now live on, right? That unit of ATP is what our cells lives on. It's what gives us energy to go about and do stuff. So you can now imagine a patient that does not have that insulin cannot live. They will die. All of their muscles go to waste. All the fat cells in their bodies burnt for calories, and they're gone. Okay, so insulin was a life-saving therapy that was discovered in 1922. Actually discovered in 1921 and then injected into the first patient in 1922. So we are now over 100 years since the discovery of insulin. So a lot of the research has been ongoing, and a lot of it was to go from having to inject this insulin multiple times a day to maybe just injecting it once a day into what we now call the long-acting insulins, right? Medications like Lantus, if you've ever heard of it, right? So we've been using this in medicine to help a lot of patients, whether they're type 1 diabetes, where they don't have any pancreatic insulin made, or they have type 2 diabetes, which is a situation where you do make insulin, but your body's requirement for the insulin is so high that you need support from an exogenous source, from an outside, to be able to now break down your own glucose intake. So in type 2 diabetes, yes, you need insulin, not because you don't make it, but because your body's requirement or the resistance of your cell to that insulin is now requiring you to inject additional insulin daily or multiple times a day. So why am I talking about this? So there was a new FDA approval for a new medication called 𝐦𝐤𝐤. Okay, I might be saying that wrong. We'll learn more how it needs to be pronounced soon, but it was just approved for what we call a once-a-week insulin. Okay, now this is major breakthrough. Yes, it's taken us 100 years to get here, but imagine that 14-year-old kid that first got the insulin that saved his life. Can you imagine if we were able to give him a shot back then and he only needed to take it once a week and he survived? I mean, that is just mind-blowing, especially because his counterparts all died in the same hospital because they just within weeks we didn't have any solution. You know, so that's major breakthrough that we are now talking about weekly insulin injections for patients with type 1 diabetes. Now, we have come a long way, not just how we inject the insulin, but also the delivery mechanism, right? So we've gone from having to inject it through needles every day, multiple times a day, to now having insulin pumps, where we implant the pump and the pump just takes a blood sample to figure out how much insulin we need, gives it to us without having to inject anything. So that's great. So we've come a long way. But here's why this has actually caught my attention. Not only are we now talking about insulin weekly injections, but we're talking about combining it with the new GLP-1 agonists. So most of you that have been listening to my channel know that I talk a lot about medications such as Ozempic, because they have been a game changer in patients that have insulin resistance, diabetes, and obesity. And now we're talking about in clinical trials, phase 3 clinical trials, that this class of medications, Semaglutide, Ozempic, are going to be combined with this once weekly insulin to actually help more patients. So we know some patients need the insulin despite, you know, needing the semaglutide to help control their appetite and to help control their insulin resistance. But combining these two medications together as a once weekly shot is going to be even more helpful for patients that we're now dealing with. Yes, I would like to, you know, get their weight down, but I don't want the insulin that they need for their diabetes to be that medication that's causing them to still hold on to fat. Because a lot of you might not realize this, but insulin, when you have insulin in your body, it's actually a signal to your cell saying, yes, take up the glucose into the cell, but in case you don't need it right now for energy, you can go ahead and store it as fat, right? So when we start combining that with medications that help us with, you know, burning fat and losing fat and eating less and feeling more satisfied, that's actually going to help us with patients that are needing the insulin for, you know, saving their lives, but also helping them not put on excess body weight in the process of getting their condition treated. So I know, you know, there's going to be comments in the comment section talking about, well, maybe they should just eat better and, you know, not need any of these medications in the first place. But everybody has to start somewhere, right? When a patient is already far down the disease path, where they need something initially to just help them get out of that rut, you know, medication like this can be a tool that we can use to try to help this patient get out of that rut. And then as things are improving, then we start educating them on how to eat better, sleep better, stress less, use vitamins, use nutrients, to try to help them do things more naturally, right? But some people can't just flip the switch like that and just go from needing 10 medications to not needing anything, okay? So these are things that we can use as tools in our toolbox to try to help patients improve, okay? So this is what is exciting me about this topic, and we're going to hear more about it as these clinical trials come through and show that, you know, they are more beneficial than risky, and we can start weighing it for each patient who this might be beneficial for. Again, the medication, once a week acting insulin is called 𝐦𝐤𝐤, and the new medication that's going to combine semaglutide with that, they're thinking of calling it 𝐴𝐸, right? So we'll see how that all plays out, and comment in the section below what you think. Is this something that you will be open to trying if you're currently on insulin, or you know someone that's having to inject insulin all the time and gaining weight and all the side effects from that? I would love to read that and hear more from you guys, what you guys think. See you on the next one.